Varun, you can
Hello and
stop sharing.
welcome
I will
to
stop
yet
sharing.
another
Yeah.
episode.
Yeah. Sorry. Yeah.
Good evening, everyone. A warm welcome and a big hello to you and greetings of the season. Wishing all of you a very happy new year, and we're welcoming post Diwali. We are back with our yet another season and session on controversies and consensus and controversies in orthopedics. And as we know that this is a season 2 and today is the 14th episode. So we'll be doing it for twice a month. And so this is our new episode with another panel of experts and our enthusiastic speakers from different part of the country. To initiate the proceedings, I would like to invite our course convener, Professor Subhranshu Mohanty, who is our mentor and who is sort of giving us the direction to conduct these programs. Dr. Mohanty is a professor of orthopedics and the head of the unit at KM Hospital, and he's also a consultant arthroplasty surgeon at Nanavati and Sushrusha hospitals in Mumbai. He has been the president of the Indian Arthroplasty Association, the past president of the Bombay Orthopedic Society. He has been an active member and a fellowship director of the Indian Society of the Hip and Knee Surgeons as well. He has got numerous national and international presentations and, of course, landmark publications in the field of arthroplasty and infections. I welcome you, Monty sir, for this program and want you to start the proceedings, sir.
Thank you, Ashish. Good evening, dear friends. Greetings from Mumbai and welcome to the 14th episode of the second session of Controversies and Consensus in Orthopedics. This time it is devoted to spine, trauma, and pediatric orthopedics. And we have three stalwarts from different parts of the country presenting the cases and another three stalwarts who will be moderating the case. Without any further ado, let us go ahead with the presentations. Let me introduce the first presenter. So first case is devoted to spine, and today we have with us Dr. Varun Khanna, who is a consultant at Artemis Hospital, Gurgaon. Dr. Khanna has finished his fellowship in National Board FNB in Spine Surgery, and he has completed his AO Spine International Fellowship in Germany. And he will be presenting a rare cause of post-discectomy radiculitis in a young male of 25 years. And to moderate that, we have with us my colleague, Dr. Tushar Rathod, who is an additional professor and head of the unit at KM Hospital, Mumbai. Dr. Tushar is a SRS active fellow. He is executive committee member of Association of Spine Surgeons of India and Bombay Spine Society. He has been an ex-member of SRS Awards and Fellowship Committee, member of the CME Committee, Worldwide Conference Committee, AO SIN Delegate Council member, and he has been an SRS Fellow and Fellow in the Cambridge University, UK, Toronto, Canada, Auckland, New Zealand. So he has moved almost all over the world. Thank you, Dr. Varun and Dr. Tushar, for joining today. Now, let me invite Dr. Varun to share the screen and present the case.
Yes, sir. So good evening, everybody. I'll be starting with the case. So this is a case of I'm presenting a case of post-discectomy radiculitis in a case of young male of 25 years. So I'll start with the history first. So this was a 25-year-old male who was into athletics, and he had come to us with the severe left-sided leg pain going down the up till the great toe and outer part of the leg, and it was L5 dermatomal in distribution, and this pain had been gradually progressive and was severely disabling this young man. And on examination, his neurology was intact and his bilateral SLR was positive. So when you saw the MRI, he had a disc prolapse at L3, L4 and L4, L5 levels. And since he was not responding to any sort of conservative treatment, and he had also tried root blocks and all heat modalities in the physiotherapy, but he was not responding to any of them. So we saw the MRI, and there was severe disc prolapse, and we decided to go ahead and address both the levels, and we did a microdiscectomy at both the levels. And post surgery, patient's pain improved drastically, and he was quite comfortable, and it was unremarkable in the post-operative period, and he was discharged the next day. But within 10 days, he returned to us with recurrent left-sided radicular pain, which was even worse than before. And again, this pain was refractory to all analgesics. His back pain was minimal. There were no constitutional symptoms. So we decided to further investigate this situation. So what were we looking at? Was this a discitis? Was this a residual fragment that we had left? Or was there a retained fragment? We went ahead and we did some basic blood tests, and the blood tests had come borderline normal, which we can accept in a post-operative period. And then we went ahead and did the MRI. To our surprise, we saw that there was similar findings at both the levels, and there was a spherical extradural mass that was there, and it was in direct continuation with the disc and at the same levels. And this mass was it was a high intensity, single intensity in the T2 weighted images and low in the T1 weighted images. It was exactly at the place where we had done the discectomy. In the stir sequence, again, we saw that there was fluid present in that both cystic structures. So what we were looking at was a symptomatic discal cyst or a pseudocyst at our discectomy site. So discal cyst or a pseudocyst is a rare cause of post-discectomy radiculopathy. It is also quoted in literature as post-discal pseudocyst, PDP. The reported incidence of this etiology of radicular pain is 0.15 to up to 1%. And the average reported time is 31.2 to 53.7 days. Multiple hypotheses have been given explaining its formation, which I will discuss in subsequent slides. We did a further literature search, and we could manage to find some 30 odd cases of this entity in the literature, and most of them were coming from Southeast Asian region, especially after endoscopic discectomies in young males, and they were managed both conservative and surgically. So the pathogenesis that has been suggested in the literature is that it can be either one because of the reaction to the epidural hematoma, or it can be because of the pseudomembrane formation at the local annulus fibrosis tear that we did during the surgery, or it can be an inflammatory response to a protruding nucleus pulposus. One author has suggested that axial loading pumps the liquid and blood in a mildly degenerated intervertebral disc to the posterior space through which the annulus fibrosis fissure was made during the surgery. So the treatment of this problem is a dilemma, because the literature again is divided into conservative or surgical treatment. In our case, we reassured this patient that his pain is because of this cystic structure at the site of discectomy, and there was no recurrent disc prolapse. And we again put him on conservative treatment. We even tried the steroid, oral steroid short course, but he did not respond to any of that, and he was severely disabled with pain with a VAS score of 8. So we decided to do the revision microscopic discectomy and decompression of the pseudocyst.
Dr. Varun, may I interrupt you here?
Yes, sir.
Yeah, it's a very interesting case which you are presenting. So I just want to know, because you showed a post-op imaging showing a cyst. So another thing which a lot of time when we do a discectomy, we take a small annular tear, and through that we harvest the fragment, because you had a kind of a content disc protrusion. It was not like a severe extrusion which was in the canal where you just do a fragmentectomy. So my concern is that can it be a annular tear which is showing a high intensity zone signal with cyst formation, and it could be a post-op finding because we did a MRI on day 10. So usually post-op imaging they do a contrast.
We did a contrast, sir,
Yeah.
and it was done approximately I think two weeks to 2.5 weeks after the surgery. We didn't do it immediately at the 10th day. We first initiated some conservative treatment. We wanted to see whether he's responding to some medications, pain medications, anti-inflammatory. We started a Medrol pack, and we wanted to
Was
see.
there any deficit also?
No, sir, there was no deficit. There was no deficit, but his pain was unrelenting and he was not responding to any sort of pain treatment. So at that point, we decided that we should go ahead and get an MRI, because usually we see through the pain if there is some off pain that we have in the post-operative period after discectomy.
Right. Right.
So we
So
went ahead and we did
this was diagnosis as a cyst, disc cyst, right?
disc cyst, post-discectomy pseudocyst. So I will come on to the further imaging, sir.
Okay. Okay.
So in this case, then we decided to, because he was not again responding to any sort of conservative treatment, so we went ahead and we did the revision discectomy. So this is the intro picture. I will just try to see if I have a video of the case, if the video works. So as we can see that this was a thin capsule and a soft fibrous tissue which contained fluid, and there was no disc fragment or hematoma, and there was no adhesion between the cyst or the dura. The wall of this cyst was so friable, the moment we wanted to dissect it out, it just gave away, and we had clear fluid coming out. So this was the same finding at both the levels, and this tissue was compressing the nerve and the dural structures and causing him radiculopathy. So what are the risk factors of this etiology of this problem that has been reported in the literature? So usually it is a young active male who has a mildly degenerated hydrous disc, and we leave the residual ends of annulus fibrosis. We do a less aggressive discectomy, and we do not fix the segment. So these are the risk factors that we found were given in the literature in most of the cases that we saw. And why young? Because in young individuals, the nucleus pulposus tissue has more water content and it is rich in type 2 collagen. And after surgery, this debris becomes highly viscous, and this promotes the formation of a cyst wall that leads to this pseudocyst formation. And the treatment dilemma is there. A lot of authors that we saw in the literature had tried conservative treatment, and they had shown that the symptoms had regression in over 6 months. But there is no universally accepted surgical indication, just that it's a tolerance of the individual and the therapeutic effect of the conservative treatment. And in our case, we had to perform the surgery because he was not responding to any sort of conservative treatment. Can we prevent this? Well, now after seeing the literature, and in this case, we think that if you're able to identify these risk factors, we remove the free ends of the annulus, and we can use cautery at the free fragments. This might lead to prevention of this problem. But this last point of cautery is again controversial, because a lot of papers that we saw have suggested that using a cautery has led to that inflammatory reaction. So this is again controversial. So the take-home message is that post-discal pseudocyst is a rare cause of persistent pain after discectomy. Clinical symptoms are just like a disc prolapse. So we can just take it that a young active male who has a minimum disc degeneration and is undergoing a less aggressive discectomy without fixation and is having persistent pain after surgery, then we must keep this option in our mind. And the treatment can be conservative or surgical as per the symptoms. Thank you.
Can I ask a question?
Yes, sir.
How often is the occurrence in the literature?
So literature is 0.15 to up to 1% that has been reported, up to 1%.
Tushar, usually, post-discectomy radiculitis, if you see, you think of an incomplete disc removal, correct?
Yes,
Exactly.
that is that. But this case was very interesting that he had a good post-operative imaging and intraoperative imaging support to show the cyst.
Yeah.
The only thing is that I would slightly differ with the less aggressive discectomy because these were like a content disc. I think the surgeon did the job. The cyst was something which was unexpected. But a
Yes,
lot
sir.
of these young patients, young kids who are very active, athletic, they do a lot of gym. We see this multiple disc level protrusion. And what
Yes,
is
sir.
important thing which I feel intraoperative is apart from doing a discectomy, which should be restricted only to a disc fragment which is obviously compressing the canal and not go like do a radical discectomy. So we only say fragmentectomy. You also do simultaneously lateral recess decompression. So if any recurrence happens, you already freed the nerve root and taken out that part. So it gives a kind of a buffer for the nerve root to take any extra pressure if there is a reherniation. So in young patients where we are not fusing the, and when we are doing just a discectomy, we are very aggressive with the lateral recess decompression. So if any future reherniation happens, if at all, then there will be some buffer for the nerve root to fall back and not get compressed. Having said that, Dr. Varun, would you think retrospectively now, could you have given a transforaminal steroid block to this patient and maybe would have got away for doing without doing because this was like fluid filled cyst?
Yes, sir. I mean, this is one of the conservative treatment option, but I think this patient was not willing for any sort of. He just wanted to get rid of the pain, which was troubling him since before the surgery, the index surgery. And if you could see that in the intraoperatively, the cyst is right at the place, and this is the nerve root where it is just compressing and getting stretched and causing him radicular pain. We had actually gone on to decompress the lateral recess a fair bit so that we can get lateral to the root in the index surgery, but still the cyst was so prominently placed at the root, stretching it, that I think we had to go in and just because we ourselves were surprised to see such a cystic structure at that place. So we wanted to just see, and we could just give him a fair outcome, like removing it completely, because in literature there have been reports where they have done CT guided aspiration of the cyst, but we didn't want that option, and we wanted to give him a solution which would just stay. And now at we are at 6 months follow up, and he's pain free. So I think it has worked for him so far.
Yeah, it's a good outcome ultimately.
So it is a diagnosis by exclusion.
Yes,
Yes,
usually
sir.
they get a
And-
post-radiculopathy. We think discitis another thing, but he had
Yes,
done.
sir. So he did
So
not have any-
MRI is diagnostic, correct?
Yes, sir. Clinically also, sir, he did not have much back pain. There were no fever or constitutional symptoms which would indicate that there is a discitis. And
SLR was restricted
SLR was restricted, sir, in the second time
and
also.
tension signs were also
Yes,
there?
sir. It was there. It was there.
Okay. Okay. A great case, great learning point. Tushar, you have seen in your practice this kind
Yeah,
of
we
pseudocyst.
see usually this kind of a high intensity zone signal, but here there were two cysts, and the disc content were kind of a content disc herniation. Normally, it's kind of a significant extrusion, so we take out the disc fragment. Usually, don't get this, but this is a rare occurrence, and it's interesting to see this.
Is this more common with endoscopic disc removal, or it is also equally seen in open discectomy or fenestration surgeries also?
So basically, the literature that we saw. So basically, the cyst formation, it can be there, but it might not become symptomatic. So this comes to light when only when this becomes symptomatic. So the incidence that we report is only the cases that have become symptomatic, and we can say that it's because it is being reported more from the Korean and the Japanese authors who do more endoscopic work than microscopic work. So we cannot say until we do a comparative analysis of microscopic and endoscopic before we can comment on that.
There have been multiple attempts to when we take an incision on the annulus and take out that disc fragment in a content. A lot of people, Japanese, have tried to close that flap to
Yes, sir.
prevent the future recurrence. But there are a lot of RCT studies which are shown it doesn't. It apart from increasing the complexity, it has not much a functional outcome.
Exactly.
As rightly pointed out by Mohanty sir, endoscopic discectomy may have a kind of a less aggressive work. What Dr. Varun also highlighted, maybe that may be increasing the chance. But open
Amongst
usually we are not seeing this. Post-op radiculitis is common because of nerve root handling, but here MRI showed a clear cyst kind of a formation. So this was a different case.
amongst the sir endoscopic cases, it is more commonly reported in the interlaminar approach than transforaminal approach. So maybe that also it goes with the intuition that we are addressing that the disc the fragmentectomy is done in the interlaminar region. So maybe that is why it is more common in the interlaminar approach than transforaminal approach.
Well, it's an excellent case, excellent learning points. First time I heard about this, post-discectomy pseudocyst. And you have very nicely shown the MRI picture as well as the intraoperative
Yeah,
video,
exactly.
which is so clear that intraoperative
Yeah.
video is clearly seen that the cyst and how the cyst got
Yes, sir. I can repeat it
ruptured.
for the sake of
Yeah.
everybody. It was so it was just at the place and stretching the root, and we tried to dissect it out, but the wall was so friable.
Yeah, it is
Moment we
difficult.
just it got in touch and it was like a clear fluid
Yeah.
coming out.
Right. Did you excise the cyst wall?
Yes, sir. We completely removed the cyst wall,
Okay.
and we even went on to cauterize slightly so that it doesn't form again.
Well, thank you, Varun. Before we move on to the next case, may I request Tushar to give concluding remarks about the case, learning points from this case.
So it's
As-
a interesting case which has highlighted about the post-op disc cyst formation. Usually post-op radiculitis day 10, when we do and when we see the patients, we usually try a conservative approach. We try to see it can be happening because of a lot of time there's a dorsal root ganglion which is sensitive and we retract. That can cause a lot of post-operative pain. It can happen. So as we discussed, it should be a diagnosis of exclusion. Promptly the treating surgeon did a hematological markers. One has to be vigilant for the discitis, which should be ruled out first. The post-op imaging is very important because, and the radiologist should be experienced because you will get a lot of edema formation here. It was not a kind of a wide conventional discectomy, so there was not much of edema, and he had a kind of a foraminotomy approach. So that gave a lot of decreased disturbance from the MRI imaging. And this cyst, as Dr. Varun has highlighted, there are always option conservative versus surgical. That depends on your patient's symptoms and response to the treatment. So initially conservative and followed by surgical, as he has shown, it can be tried in this kind of cases.
Thank you so much, Dr. Tushar, for concluding those cases, and thank you, both of you. So
Thank you.
let me move to the next case. So next case is on the trauma, and to present that we have Dr. Imran A, who is working as a senior registrar at Ganga Hospital, Coimbatore. Dr. Imran did his MBBS from Government Mohan Kumar Mangalam Medical College from Salem in Tamil Nadu, followed by his diploma in National Board in the Ganga Medical Center and Hospital Private Limited. And he's going to present interesting cases in distal radius fractures. And to moderate, we have our close friend, Dr. Iqbal Singh Ghai, who is Associate Professor at Government Medical College, Amritsar. Dr. Ghai is a Secretary of Punjab Orthopaedic Association and Secretary of Amritsar Orthopaedic Association as well. And he is an ex-Vice President of Punjab Orthopaedic Association. Thank you, Dr. Ghai and Dr. Imran, for being there for the cause of academics. I'll stop sharing the screen and request Dr. Imran to share the screen.
Thank you, sir. Is my screen visible, sir?
Yeah, visible, but please make it full screen, presentation mode. Just click on that.
Yeah, just click on the button. Orange one.
Orange one. Right lower corner. Right lower corner. Yeah, good. You stop
Sorry.
sharing.
वो बंद कर दी.
हाँ, बंद हो गया.
Yeah.
Yes, sir. I am presenting a few interesting cases in distal radius fracture. Distal
Can you
radius,
make it full screen?
is it in full screen only, sir?
It's not in full screen. It's in the presentation mode.
वो नहीं गंगा हॉस्पिटल में काम कर रहा है ये उसका कर्सर उधर आके रुका है It's just not clicking.
Okay, no problem. You can go ahead with this also. No problem.
Yes, sir. So here it is a 28-year-old male. He had a fall on outstretched hand with this presenting X-ray. So we are able to see in a anteroposterior view, there is a double density.
Can you move the slide
No, no.
forward? Slide is not moving.
Imran, you go to the full screen because your slides are not moving. Or you go to the next slide. Yeah.
Yeah.
Now you are
Now-
able to see, sir?
Yeah.
Yes, sir. Here it is a 28-year-old male had a distal radius fracture. In AP view, we are able to see the double density, and there is a double mark in the joint. And in lateral view, there is completely intact articular surface. And then there is a dorsally tilted lunate fragment. And then the CT shows there is a dorsal rim fracture along with the depression in the intermediate column and completely intact and the volar cortex. So this is called a dorsal fracture with the impaction. So it is classified as a partial articular fracture and AO as a B2 fractures. So how to proceed with this fracture, sir? So we went ahead through the dorsal approach. So the dorsal approach is the landmark is a Lister's tubercle. Centering the Lister's tubercle, the proximally there is distally there is 2 centimeter and proximally 7 centimeter. We can incise skin incision, and the second thing is once we enter the retinoculum, we should identify the EPL tendon by the flexing and extensing the thumb. We are able to identify the EPL, and then we need to incise the EPL in line with the tendon. Once we incise the tendon, we need to mobilize the EPL, and then if we need to visualize the articular surface, as seen in this case, we are able to see the articular impaction. So we incise the capsule in line with the distal radius articular surface. So to find out the joint, we use the K-wire K-wire placed to identify the joint. So after incising the capsule and subperiosteal elevation of the other compartments, we are able to see that clearly there is a joint impaction and the lunate. So subperiosteal, the other compartments were elevated subperiosteally. And the reduction comes once we reduce the lunate with the come into the alignment, the articular surface were elevated, and then elevated, the gap is filled with the allograft. So we are able to see the nicely reduced the articular surface with the congruent joint, and then the lunate fragment, the lunate dorsal fragment was buttressed with the low profile plate, and then the styloid fragment was buttressed with the styloid plate dorsally. So we are able to see the post-op X-ray with the nicely reduced the congruent articular joint in AP view and lateral view. At 1 year follow-up, he had a same the alignment of the lunate is maintained, well maintained. So he had a good clinical results also. They had able to do the good plantar flexion and dorsiflexion. So this is the case 1. In case 2, it is a similar case, but here we are able to see that there is a completely subluxed lunate column along with the joint. The difference between the previous case and this case is, previous case there is a dorsal shearing fracture with the impaction, but here the fracture is a radiocarpal dislocation. The difference is in radiocarpal dislocation, there will be a dissociation from between the articular surface and the carpal. We are able to see the CT image. There is a lunate is completely displaced, So this and one more important thing in radiocarpal dislocation is it is the mechanism by hyperextension and ulnar deviation and hyperpronation. This leads to there is a transition force that occurs from the lateral to the medial aspect of the radius surface, and there is a avulsion of the volar ligaments. So and the because of the hyperextension and the shearing force, there will be impaction from the subluxating corpus against the dorsal margin of the radius. So here we should recognize this volar capsular injury. Then only we are able to repair the volar avulsion lip fracture. It is the fundamental to maintain the stability of the entire corpus. As seen in this case, we initially went through the volar approach and then used the suture anchor to repair the volar capsule, and then we went to the dorsal approach, and then the impacted fragments were elevated and the dorsal fragments were buttressed with the dorsal plate. So at the end of the fluoroscopy image, we're able to see the nicely reduced the articular surface in both anteroposterior and lateral view. So this is the final clinical image. And post-op X-ray, we're able to see the good congruent joint with K-wire in situ. We removed the K-wire at 4 weeks and then we started mobilization. At 1 year follow-up, we had a nicely reduced joint, and we're able to see the volar and the dorsal incision with a nice, good clinical outcome. The other indication of dorsal approach is associated carpal injury. It is also a similar case with the styloid fracture with impaction. Here, the associated with distal radius fracture, there is carpal injury. So again, we went through the dorsal approach and we identified the depressed fragment and elevated and fixed with the dorsal plate. At the same time, we repaired the carpal bones and ligaments and fixed with the K-wire. At 4 months, he had a good outcome. So there are indication for dorsal fractures in literature. So the first case we discussed the dorsal shearing fracture, and in the same case we are able to see the articular fracture. So the main advantage of dorsal approach is we are able to clearly visualize the articular surface only through the dorsal approach, not by the volar approach. And another indication is the ipsilateral carpal injuries. So advantage is we are able to the opportunity to make the orthotomy and directly view the articular surface, and we are able to elevate the depressed fragment, and we can address the address concomitant carpal injury such as scaphoid fracture and ligamentous tears. But the complication with this dorsal plating is the hardware prominence up to 23% and has been reported, and there will be the tendon injuries. These are all the complications were reported with the dorsal plating. But still, the dorsal plating with the new low-profile implants still deserve a place in the armamentarium of for some of the particular type of dorsal rim fractures. Thank you, sir.
Thank you, Imran. That was an excellent demonstration of dorsal approach in various radius fractures. And over to Dr. Ghai Saab.
Imran, you can keep the X-rays, Imran.
Sir?
You can keep the X-rays on the screen while the discussion is on.
Yeah.
Just my question is that you mobilize these patients immediately after surgery?
Sir, still suture removal we will keep 2 weeks in slab, sir. After 2 weeks, we will start mobilizing, sir.
And these plates must be irritating the tendons on the dorsal surface. So do you take them out early after the fracture union, or you keep them for longer?
Sir, unless the patient is symptomatic, we won't remove, sir. If actually we had some of the patient with hardware prominence, we removed, sir. Yeah. But in these cases, the patients were comfortable, still not, so we didn't remove, sir.
Over to Dr. Iqbal, please. Yes, sir. You unmute yourself.
Imran, can you show the X-ray, please? Yeah.
Yeah. Ashish, anything?
Yeah, these are it's a very excellent presentation. Excellent presentation. So, I mean, these are very, very tricky fractures. And a lot of times we end up thinking whether we should put a volar rim plate and try to get an indirect, reduction. Like it's like trying to close the door from the first floor or the ground floor door, something like they do in acetabular surgeries. But these warrant a dorsal approach. And these fragments are so friable intraoperatively that, you hold it with forceps also, they can get crushed.
Yes, sir.
But we will be seeing more and more of these as the osteoporotic fractures, and our understanding of our CT and the mechanisms are also sort of increasing. So they nowadays, sir, we are again going towards a fragment specific fixation, even in lower end radius, like they had in the proximal tibia or even the distal tibia. So they say that whatever fragments are broken, you need to buttress that and push that in place and treat like a pylon or a plafond fracture, elevated, bone grafted. But an excellent demonstration of clear, good pictures, good illustrations. Very nice.
And
Yeah.
yeah, please.
Yeah, sir.
Yeah.
So in the first case, you
Yes,
have done the allograft packing.
Yes, sir.
Can you tell me what's the depth of the compaction? How much the bone is compressed?
Sir, actually in literature, the regarding the allograft, has been in distal radius, it is not recommended because in a
Yeah,
weight bearing
yeah,
zone,
yeah.
we went through the literature in in weight bearing zone like proximal tibia, or it is recommended to keep the allograft. One study is there in comparing the weight bearing and non-weight bearing. There is no role in keeping the allograft
Allograft.
distal
Yeah,
radius.
in the
But
distal radius.
yeah, but we
Yeah.
used as a reduction tool, and we should we because we are having the facility of allograft, we used it, sir. Here depth, actually I don't know exactly, but there is this is the cervical spine allograft, sir. We kept a very small amount of allograft. It is almost a
Okay, it's fine.
2 to 3 mm,
But
2 to 3 mm.
but my second concern is about the tendon injury.
Tendon?
Tendon injury.
Yes, sir. Yes,
I
sir.
I had my tendon injury.
Okay.
My case was operated, but I had that after 9 months.
Okay.
9 months of the surgery, patient was doing well,
Okay, sir.
and suddenly he came with the loss of EPL
Okay. Okay.
after 9 months.
Okay, sir.
Like
But
a attrition injury to the tendon.
Yeah,
Yeah.
that what I am coming to, it may be continuous rubbing and thinning of the tendon, leading to tendon rupture after that time.
yes, sir,
So
it is reported definitely up to 20 to 40% has been reported in the literature. But with the advent of low profile plate, it is one of the study I quoted, they have reported up to, it is reduced up to 6% in their study with the low profile plate. But definitely the complication is that the hardware prominence is there, tendon, but
yeah,
we didn't had the tendon injury. But hardware prominence, some of the thin patient, female patients, we need to remove the implant, sir.
so coming to the Dr. Mohanty's point,
Yes, sir.
removal of the implant.
Yes, sir.
And after that, I made it a point, the bone united, remove the
Yes.
implant.
Yes, sir.
Either this is causing problem to the tendon or not. I remove every implant after that.
Okay.
Because you never know how it is going to behave afterwards.
Yeah.
I'm that good of thoughts.
Yes, sir. But with the low profile plate, with the gentle handling, will be fine, sir.
Yeah. But it's a beautifully done cases,
Yes, sir.
beautifully reduced, and good results.
Yes, sir. Thank you. Thank
Now,
you very much.
nowadays, I advocate every implant should be removed after it has done its job. Because the longevity is increasing, and
Yeah.
implant related complication, whether it is
Complications,
infection,
yeah.
implant failure, or stress fracture,
Yeah.
whatever you tell, there are a lot of things. And after we are doing more and more joint replacement surgeries nowadays, especially around the knee and the hip region, I told it's preferable that let us take out the implant after it has done the job electively, rather than waiting for the when something else is required. Because that time it will be difficult to take it out. At least take it out after 2 years or so in an elective manner. So after it has done the job, that is what nowadays there is a classification also peri-implant fractures by AO. This has come recently, couple of years back in Injury Journal, peri-implant fractures classification.
From the periprosthetic, they have come to the peri-implant fracture now.
Exactly, peri-implant fractures classification. So that means there must be increasing number of peri-implant fractures. That is why they have come with a classification like that. That is the thing.
So now this school of thought of removing the implant when the bone has united is coming up now.
Yeah. Previously, we were thinking, okay, young patients, you take it out, old patients, you can leave it like that. But I think you can at least suggest to the patient, it's of course the patient's choice. But at least we can suggest to the patient, you take out the implant, it has done the job, and why unnecessary keep it?
Okay, one question to the doctor.
Yes, sir.
Well, when you started the physiotherapy, number one, number two, how you go for the physiotherapy?
Sir, physiotherapy till suture removal, we'll keep it in slab, sir. It is 10 to 2 weeks. After the 2 weeks, we will start passive mobilization of the distal with the wrist palmar flexion and dorsiflexion, sir. And then pronation supination exercise we will start.
When you start this pronation supination, I can understand dorsiflexion, palmar flexion, you can start immediately.
Yes, sir. After 2 weeks, we will start passive mobilization, sir.
No, so you go for supination, pronation at the time of dorsiflexion and all that, all the
Yes,
4 exercises, or you just wait for the first dorsiflexion and dorsiflexion will be coming normal. Then you start the supination and the pronation, or all the 4 exercises at the same time.
Yeah, all the exercise at the same time, sir. Is there any difference, sir?
Yeah, there is a difference.
What the pronation supination puts a lot of stress on the joints and the rotational stress.
Yeah, okay. What the literature says, you go for the that dorsiflexion and all that first, then wait for some time, then start the supination and pronation. That is by the end of the 4 weeks.
Okay.
By that time, the bone is slightly adherent and proper fixation is there.
Okay, sir. This is new. I have learned down. Okay.
Yeah.
Okay, sir.
But excellent cases and excellent demonstration of the approach, how you reduce the fracture and how you put the grafts are all freeze-dried allograft or pressed?
Yes, sir. Freeze-dried, sir.
Irradiated grafts.
Yes, sir. Irradiated.
So
Gamma irradiated, sir. Gamma irradiated.
Why you can take grafts from the autograft from the say olecranon or something? They must be requiring very little graft, no?
Yes, sir. Yes, sir. Yeah, that's what I told, because of availability only, sir.
Okay.
We had a option, so we used.
Okay.
Yeah, other option, olecranon, we can take it, sir, definitely.
Okay. Yeah. And when you cannot engage a fragment, suppose a small fragment, styloid or something like that, do you, in addition to that, put a K-wire or something like that to reinforce the fixation?
Yes, sir. In few cases, we used K-wires also, but in this case, we were able to fix the fragment with plate itself, sir. We are able to buttress it.
Okay.
Yes, sir.
Thank you.
Yes,
thank you, Imran. Excellent cases and excellent demo. Before going on to move on to the next case, may I request Dr. Iqbal Singh Ghai to give a concluding remarks on this case.
This is nicely done case, properly reduced and well fixed with a minimum small implant and good results. It's good thing that there are the small implants. They are not causing any injury to the tendon, local tendon. But that is on spot. On spot injury is not there, but injury may be there after a few months or so, due to the attrition of the tendon, might be possible that there might be some reading of that tendon there. So, in conclusion, what I say, the implant should be removed when the bone has united. No doubt it's a second surgery, but the patient is off for the complication throughout the life. Those complications throughout the life of patient is off from that.
Okay.
And that's my concluding. But it's a good done, well done work.
Thank you. Thank you, Dr. Imran A, for your time, and Dr. Iqbal Singh Ghai for your time for the cause of academics.
Thank you, sir. Thank you for the opportunity.
Welcome, sir.
Thank you, sir.
Welcome, sir. Welcome. Okay, bye.
Bye. Thank you. Can you stop sharing, Imran? Yeah.
Yes.
So let us move toward the last set of cases, that is the pediatric orthopedic case. And for that, we have with us Dr. Ankita Khajuria from, she's a final year resident of MS Orthopaedics at GMC Jammu. And Dr. Ankita is pursuing his MS Orthopaedics at Government Medical College Jammu, and she claims to be the first female orthopedic surgeon in MS Orthopaedics from the Union Territory of the Jammu in the history of 51-year history of GMC Jammu. Thanks for taking up orthopedics, and welcome to our branch, Ankita. And on the other hand, in Telangana and other states, there are 33% reservation for the female candidates, and there shortage of female orthopedic surgeons, as I learned. And we have in KM also, we have lot many girls joining orthopedics. So thanks for joining here. Dr. Ankita has won the Best Poster Award in the 9th Annual Jammu Trauma Meet by Jammu Trauma Society. And she is the first runners-up in the IAA Gold Medal paper presentation at the IAA in October 2023. And I have heard her presentation in total knee arthroplasty extraarticular deformity. It was an excellent presentation. She has contributed also in the book written by our friend Dr. Abdul Ghani, and a handbook of fractures, the current concept and musculoskeletal pain management. So welcome, Ankita, to this episode of Controversy and Consensus.
Thank you, sir.
Thank you. And to moderate that, we have our very close friend, Dr. Sandeep Patwardhan, who is a KM Ortho alumni again. And Dr. Sandeep is a well-known pediatric orthopedic surgeon all over the country. People know him, and he's a professor in orthopedics at Sancheti Institute for Orthopedics and Rehabilitation, Pune, and he's the Vice President of Pediatric Orthopedic Society of India. Thank you, Sandeep, for joining today in this episode.
My pleasure.
Now,
good evening, sir.
Good evening. Stop sharing the screen, and Ankita, could you share your screen and present your case?
Yes. Should I begin, sir?
Yeah, please.
Good evening, everyone. To all the faculty members, I'm honored today to present a case at such a distinguished platform with all the mentors who continue to inspire us. I'll be presenting a follow-up case of DDH, developmental dysplasia of the hip. As we know that earlier, DDH was earlier called CDH, that is congenital dysplasia of the hip. That is now the terminology has changed. It is called developmental dysplasia for a few reasons. That every hip is not dislocated. It can be either dysplastic, or it can be subluxated, or it can be unstable. And also every hip that is dislocated is not congenital. So that is not by birth. That is why the C has been replaced with D. Then coming to the history, we had a 5-year-old female with she had a complaint of limp, and that was noticed by the parents when she started walking. And there was pain over the left hip since 1 year. So usually an older child usually presents with a short limb gait and a painless hip and some asymmetry in unilateral cases. And pain is usually sudden in onset, and it was progressive in nature. So just ruling out the negative history, there was no history of any fever or any trauma, no significant family history. The baby was born by normal vaginal delivery. She was a firstborn child, female, and the parents had a consanguineous marriage. Why we are asking this is because there are certain risk factors like breech or firstborn female child, or these kind of risk factors, they predispose to DDH. And there are the hip ligaments are lax. That is because of the maternal hormone and the relaxin that is produced. And coming to general physical examination, patient was conscious, cooperative, and alert with a normal build, and she was oriented to time, place, and person. The knee and the foot examination are normal. This is because we want to rule out any there is CTV or metatarsus adductus or any congenital dislocation of the knee. All these things have to be ruled out. This is the child. We can see that the level of the shoulder on examination, on inspection, is bilaterally equal and symmetrical. The level of the anterior superior iliac spine was same on both the sides. The knee and the patella on the left side was slightly higher than the right in preoperative pictures, and there was no visible wasting. However, there is increased lumbar lordosis and abdominal protrusion. Rest of the findings are normal. The spine curvature is normal. The level of gluteal folds and the posterior superior iliac spine is also normal. This is the movement as described in the pictures, that she was able to squat easily and cross-legged also. However, there was slight restriction in abduction on the affected side, that is the left side. Rest all the movements were normal. There was no fixed flexion deformity in the hip, so the Thomas test was negative. Coming to the special test, we performed Galeazzi test and looking tangentially at the knee, it looked at a different level. So we suspect DDH. And when we measure it, it came out to be 1 centimeter supratrochanteric femoral shortening. And usually this is done for older children. For younger children, we go for tests like Ortolani or Barlow's test. And those can be done for less than 2 months of age group. Coming to the further Trendelenburg test, which was positive, and also telescopy test was positive in this child. On the affected side, we can clearly see that the pelvis droop is positive. So that is on the affected side, the left side. We measured the true and the apparent lengths, and there was shortening of 2 centimeters, both in the true and apparent measurements. And also we confirmed these by using the Bryant's triangle, the Neleton's line, Shoemaker's line, and the Kynes line. All these were confirmatory. Yes, sir.
Yeah, go ahead.
Sir, so all these were confirmatory, and we just happened to confirm the findings that it was a supratrochanteric shortening. Then coming to the gait, we can see that this child had a visible limb length discrepancy here. There was a Trendelenburg gait. So the compensatory lurch towards the affected side can be easily seen while walking. She had a contralateral knee flexion during stance phase, and affected shoulder moves up and down. And the affected side hip sags down while bearing the weight. In a bilateral case, the waddling gait is seen with the large perineal gap and with hyperlordosis. So this was the gait. This was preoperatively. So coming to the X-rays, mostly there are certain things that we need to enumerate when we see the X-rays of these patients. Perkins line is a vertical line from the outer border of acetabulum. The Hillgren-Riener's line, that is the transverse line going through the triradiate cartilage. So we remember like H for H, the Hillgren-Riener's line is the horizontal line. The position of the femoral epiphysis determines whether the hip is subluxated or dislocated. If it is in the inferior medial quadrant, it is a located hip. If it is in a inferior lateral quadrant, it is a subluxated hip. And if it is a superior lateral quadrant, it is a dislocated hip. And the Shenton's line, that tells us whether the hip is in the center. We take the frog leg lateral views, and we see the Von Rosen line, which is drawn along the shaft. And we also look for increased medial gap in the X-rays. The acetabular index and the centroid angle of Viborg are also seen. So this is the X-ray of the child. The lines were drawn, the Hillgren-Riener's and the Perkins line were drawn. The Shenton's arc is broken, and the femoral head ossification is superior to the line, whereas it should be inferior to the line. And the femoral head ossification is in the upper lateral quadrant. The acetabular index and the centroid angle of Viborg are both abnormal. We can also use graph classification on ultrasound. So for ultrasound, usually this is used for infants, not for older children. So advantages for ultrasounds are many. It can be used to see the cartilaginous structures. It provides a 3D orientation. It is a dynamic study and sensitive and very safe because there is no radiation involved, and provides immediate results. Also, we can check the stability during Pavlik harness and bracing, and we can monitor sequentially. So it detects any posterior dislocation and evaluates the acetabular development. It also gives an anatomic evaluation of the hip without exposing the infant to radiation. But there are some disadvantages, like it is a higher cost and it is highly operator dependent, and there might be false positive cases, and is less useful for children who are older than 9 months. So we can see that in the graph classification, graph 1, 2A are normal, and 2B is also considered to be normal. 2C onwards, we see that it is unstable or dislocated hip, and the alpha and beta angles are measured, which tells about the bony and cartilaginous roof and the position of the femur head. So alpha angle decreases and the beta angle increases. Just a little bit about the management guidelines. So management is basically we focus on early management, which involves repositioning of the reducible hip and the reduction of the dislocated hip. So for that, it is age-wise management is given. For 0 to 6 months, we go for Pavlik harness. Usually, Pavlik harness guides the hip into flexion and abduction, and the spontaneous kicking of the child allows gentle reduction with the low.
Can I interrupt? Can I
Sure,
interrupt for a
sure,
moment?
sir. Sure, sir.
Dr. Mohanty, are we doing
Yeah.
a lecture or a case presentation?
Actually, it's a case presentation, and she has included a lot of theory also into the presentation.
I
So
think she's taking a lecture for us
so you can
because
discuss,
I
no
don't
problem.
see the relevance of all this. It's like reading a textbook lecture.
I'll skip those parts. I'll come directly to the.
Yeah, just
Yeah, because I don't understand whether you're doing a. See, there has to be clarity, Ankita.
Yes, sir.
You are a resident. I don't know whether you're trying to present a case for your exam, whether it's a case for clinicians, whether you
Okay,
want to teach us about DDH. I have no
Okay,
clue what you're talking. You're all over the place for me.
Okay, sir. Sir, I'll
just
stick to
talk
the
about the case, no?
case. Okay, sir.
Yeah.
Right, sir. So the case, this was the intraoperative picture. We did a varus derotation osteotomy and femoral shortening in this child. And anterior approach, Somerville approach was used. That is most widely used. We gave an incision, a T-shaped capsulotomy, and we removed all the intra-articular obstacles, and we reduced the head and did a tight capsulorrhaphy, and followed by K-wire fixation and cast. So this was the image after K-wire fixation. And this was done immediately after that. Hip spica was given, and usually acetabular procedures can be done, but in this case we did not feel the need, so that is why we only stick to the femoral osteotomy and the derotation. So post-operatively, this is the X-ray that came up, and we can see then the Shenton's arc was formed and it was intact. And so the femoral capital epiphysis has started remodeling, and now the position of the head is inferior to the Hilgren-Riener's line. And also it is in the quadrant, in the lower medial quadrant. The acetabular index and centeredge angle also have improved. This is the post-operative examination and pre-operative examination. So I put a comparison. So the lumbar lordosis and the abdominal protrusion has returned to normal post-operatively. And also the shortening has disappeared, sir, on the left side. And all the parameters that were clinically, they were abnormal pre-operatively, like the Nelliton's line and Shoemaker's and the Kynes line, they have now turned to normal. And also the post-operative evaluation, this was the gait at 8 months. So the child has bipedal unassisted gait with equal stance and swing phase, and there's no visible limb length discrepancy, and the Trendelenburg gait is negative. The telescopy was also negative, and now she's able to perform her activities of daily living without any difficulty. So that was about the case, sir. Thank you, sir.
Okay. So how did you arrive at the just before Sandeep takes over the discussion? How did you arrive at the decision of doing this surgery in this particular child?
Mostly whenever
what are
we
the
see that
indications of doing? Yeah.
Yes,
You
sir.
can just
So-
keep your X-rays on, post-op
Right,
X-rays
sir.
and all,
Right, sir.
and while the discussion is going on.
Yes, sir. So mostly we go for surgery in case of either if there is a closed reduction that is not possible, then we go for open reduction. In unstable cases and for age groups more than 3 years, if usually that is for an older child, I mean to say. So that is when we go
Ankita,
for.
again, don't go to theory. We are talking of a practical scenario. You
This
have
case,
told us this is 5 years old.
Yes, sir.
You are drifting back to theory too often.
Okay. Sorry, sir.
In this particular case, Dr. Mohanty is asking, how did you make the decision?
Yes, sir.
What surgery you want to do?
So we made the decision because of a clinical presentation. This was a case of delayed presentation of DDH. She came to us at 5 years and with significant disability in walking. There was limp and in an older child. After assessment and after the X-rays, we assessed the patient and we saw that because of the delayed presentation, it would be better for the child to go for an operative intervention.
So what was the pre-operative acetabular index?
Sir, the pre-operative acetabular index was
so the preoperative X-ray.
yes, sir. Just a second, sir. So it was 35 degrees on the left side, sir.
35.
Yes, sir.
And how much is normal?
So normal is, it should be less than 30, sir.
Less than
30 degrees,
30?
sir. Yes, sir.
30 is also too high.
So
Okay,
25 to
so
30.
now that you have, yeah, so at 5 years, what is the acetabular remodeling that you expect?
Sir, as the age progresses, the acetabular remodeling, the chances of remodeling are lesser and lesser. So
this is 5. No, again, no theory. You are at 5 years.
yes,
You
sir.
have a neglected DDH. You have an
Right,
acetabular index of 35.
Right.
What made you decide that I will not do an acetabular surgery?
Once, because when we intraoperatively, when we saw that after incising the capsule and we were able to reduce the hip and it was the femoral head it was coming back to its place. And we just fixed
It
it
was
with
easy. Was it very easy? It's a 5-year-old child. Muscles are well developed.
yes,
Was
sir.
it easy to get the reduction? What are the problems with reduction at 5 years?
So there can be intra-articular structures which can impinge, like
No
pulvinar and
theory.
yes,
No
sir.
theory. No theory. What was the problem?
So there was hypertrophy. In this case specifically, there was hypertrophied ligamentum teres and the transverse acetabular ligament. So we had to release
So
both of them.
what happens in what are the extra-articular problems which prevent a reduction? Do you get a reduction very easily? You do the capsulotomy, you
Yes,
do
sir.
everything. Can you pull the hip down at 5 years?
Sir, there are extra-articular, like you said, probably iliopsoas muscle or there might be.
So you lengthen the iliopsoas?
No, sir. We did not lengthen the iliopsoas in this case.
How can you get a reduction without lengthening the iliopsoas or tenotomizing it at 5 years?
Okay.
Did you assist the surgery or you are just
Yes, sir.
presenting the case?
No, I assisted the surgery. It was 9 months
So
back.
tell me stepwise, what all did you see?
So first of all, we went through the anterior approach, and we went.
What is the approach?
So in between the sartorius muscle and the tensor fascial lata.
Okay.
Then afterwards, we went and we dissected the soft tissue dissection. After that,
No, after that something comes in front.
Uh,
See, you are
so-
becoming an orthopedic surgeon now, Ankita.
yes,
You
sir.
have got best awards and all, right? So you have to tell me correctly, when you went into the plane between Sartorius and TFL, what was the next structure that you saw?
Uh,
The next plane.
sir, I'm sorry, I am not able to recall right now.
You cannot say I dissected the soft tissues if you have seen the surgery. After that you will get the rectus femoris on the front of the
Yes.
capsule
Yes, sir.
from the anterior inferior underlifted head from the capsule. Unless you detach that, you can't clear the capsule.
Right, sir. Yes.
Yeah, so when you detach the rectus, then you will see the capsule. Then you will do your capsulotomy in whatever way. You place sutures first at the rim, or you do it later, but you make your capsulotomy. And then you will see the iliopsoas medially, which you have to first tenotomize. Otherwise, the hip is never going to come down. The single most important cause of recurrence after DDH surgery is not cutting the iliopsoas.
Okay, sir.
After that, your head is going to be lying up there, superolaterally, next to the ilium. Right? And then you have to trace the ligamentum piece from the acetabular socket. And then detach that and clear the acetabulum. The next question I'm going to ask is that how do you know adequacy of clearance?
Sir,
How do
that
you know
is
that you have done a good job?
so intraoperatively?
Yes. Everything is intraop. You're on table, you are operating surgeon, Ankita.
Sir, using an arthrogram, we can
Arthrogram
assess.
after opening the hip, why do you want arthrogram? Your eyes, you are able to see, no? When you do
Yes, sir.
close reduction, you use arthrogram.
Right, sir. Sir,
I don't think you have seen it. You are talking a lot of theory. When you go into the hip joint per se, you will see that there is fat, fibrous tissue. When you remove that, you have to go inferiorly to the transverse acetabular ligament.
yes, sir.
And when you cut that, there is a sudden gush of blood. Unless you know you have reached that point, you have not reached the end of the acetabulum inferiorly.
Okay, sir.
Okay, that is the adequacy of clearance of acetabulum that you need to do. Then you will give traction and see if the head comes down, which at 5 years it will not.
It will not.
In fact, when you showed your X-ray, you said you did femoral shortening, and you are saying it came very easily.
Right, sir.
It cannot come, no? You have to make the osteotomy, and then with the bone holding lever, pull the head down, and then you get the reduction. Then you see the best fit. In which position is the head fitting well? Is it abduction? Is it flexion? Is it internal rotation? And then you see how much is the fragment overlap. How much is the distal fragment overlapping? So you will temporarily transfix the head into the socket in the best fit position. Then see how much is fragment overlap. And depending on whether you need abduction, internal rotation, you will do a derotation varus. If it is only internal rotation, you do only derotation. If it is abduction required, then you do varus derotation. And then you will shorten appropriately. Now, when you have shortened, your plate on your X-ray looks anterior to me. If you see your X-ray, the plate should be lateral. So the plate placement is also quite anterior in your post-op X-ray. And finally, then you remove the K-wire and check stability by push-pull. You understand what I'm getting? And then you make the decision whether acetabular dysplasia is very high. Given the age of the child, 5 years, less likely that it will remodel. So you have got your reduction, you have got your stability, but the acetabular dysplasia has to be addressed by doing a Pemberton. And you use the fragment which you have removed for shortening as a graph. Okay, and then you may still keep a transfixing wire, give a spica, and then rehab. Now you tell me, you said pre-op there was 2 centimeter shortening.
Yes, sir.
After your reduction, your length should come to equal. But you have done shortening to get the head down. How much shortening you did?
So it was, I think, 1 centimeter.
So then how post-op you're telling leg lengths are equal?
Sir, on
You're telling
this-
us post-op video you're showing and saying that legs are equal in length. If
Sir,
you're
there was-
shortened,
yes, sir.
the leg has to be short.
So there was a mild discrepancy, 1 centimeter, which was not visible when the child is walking. It was not apparent. So
अंकिता ऐसा नहीं छूटने का कोशिश करने का. You have to be logical, you know. You said 2 centimeter shortening. I had to do shortening of 1.5 centimeters. So you are going to have shortening post-op. And with a varus osteotomy, you will have further shortening.
Further
Right,
shortening,
sir.
yeah,
So
that's
you
what
get
I
a
was telling.
stable hip, but the child's limb does not disappear. Please remember that. They will have varus lurch. They will have some Trendelenburg. They will have some shortening, which over the years will remodel. So you have to show me 5-year follow-up X-ray showing that acetabular index has reduced and the lurch has gone away and the leg has straightened after implant has been removed. You have
My
not shown
question,
that X-ray.
my question, Sandeep, you take about acetabular procedure decision intraoperatively or you decide preoperatively?
So that's a very interesting question. So when we do our DDH surgery, we have to realize and differentiate between two things. One is dislocation, second is dysplasia. The dislocation has to be open reduced for good stability and good fit to encourage the dysplasia to remodel. But the remodeling of the dysplasia is very good provided child is less than 3 years of age.
Okay.
As the child gets older, the dysplasia is better addressed simultaneously at the same time. Very rarely do you do stability के लिए acetabular procedure. You do that is for residual dysplasia.
Yeah.
Your stability is achieved by good open reduction and a varus derotation osteotomy, and you treat the dysplasia by acetabular procedure. Only unless your anterior and anterolateral acetabulum is deficient, which means you need to flex the hip for stability. If in extension the head is dislocating, then you do a salter or something to cover it anterolaterally to enhance stability also. But most of the times you will do a stability surgery, open reduction, varus derotation, and the dysplasia surgery is the acetabular procedure. And older the child, the more chance that you have to do acetabular procedure. Okay, and
So it
your
is the-
psoas has to be cut.
Okay, sir.
So it is the age of the child as well as
Yes.
intraoperative
Yes.
coverage.
Yes. Yes.
Both the things you take a
Both
decision.
things are important. Yes. So giving stability is enough if child is younger and it's a idiopathic kind of a non-arthrogrypotic child, non-syndromic child. Whereas if you have other problems or if there is older child with higher dysplasia, you had better address that at the same time. Because later on they will come to you for residual acetabular dysplasia and progressive pain and subluxation, and they will end up with arthritis. So older the child, the better that you do acetabular procedure simultaneously. So confidence apni jagah, Ankita. Content has to be well understood before you present, right? So presentation was good. You are very bold, confident, but don't talk so much theory.
Okay, sir.
At 5 years, why are you telling us graph angles and alpha and beta? Are you aware of the National DDH screening program of India?
Sir, I read about it.
Yeah, what did you read? Tell me.
Sir, that the screening of DDH usually involves it has to be done in infants where there are, for example, a child with metatarsus adductus or.
Ek minute, Ankita. Again, no theory. Have you read the paper which has been recently published by POSI members and IAP members and FOXY members in Indian Journal of Orthopaedics? For many years, we did not have a national screening program. Recently, we have had a consensus statement and a publication which defines the Indian screening program for Indian babies. It should be implemented at all centers. We are trying to popularize it through POSI. You should read that paper and see whether we are going for high risk screening or universal screening. And what are the criteria? There are clinical screening and there are sonological screening. When to do what? It's all very clearly written. So today you must go and read that paper and remember that, because you should be able to quote it and tell us that screening program is when you do ortolani and Barlow, not in 6 months, 5 years, right? And we do have a screening program now which is published. We need to implement it on a national scale.
Right.
So be very sure when you talk what you are talking. You cannot just beat around the bush and use generalizations.
Right.
Yeah. Thank you. Thank
Thank
you,
you, sir.
Ankita. I think it
Sorry
was
for
a
being critical, Ankita.
No,
but,
no, sir.
no,
I'm
no.
learning,
It was
sir. Thank
it
you,
was
sir.
a
Thank you, sir.
pre-examination. It was a test for her. So it was a practice how to appear in the
Thank you.
practical examinations. So you had a test of it today. So you can go and it will give you a boost to read. And
Right.
thank you for preparing the
Don't
case
get
at least for
disheartened. It's a
Sir, no,
difficult
presenting it.
topic. You presented it confidently, but
Thank you.
be very, very careful in your exam that you talk about the case, not theory. When
That
you
is
are
the
asked, Dr. Mohanty is telling you something specific, you don't start saying that I can do this, I can do that. You have to tell
That-
what you will do now.
That is what
Right, sir.
happens during PG exams. You know, you rather than talking about the case, you start talking about the theory. Please remember that.
Yeah,
sir.
and if
Okay.
you start doing that, now the examiners are disinterested. They will start eating chana and that shengdana and whatever, kaju, and then you don't pass. And
sir.
we hope that you are the first pediatric orthopedic surgeon of Jammu State.
Thank you, sir.
Okay.
Thank you very much, sir.
Thank you for presenting the case. Before
Thank you, sir.
closing,
Thank
may I ask Sandeep just to give concluding remarks about this particular case?
Right. So
One
the interesting part about DDH is, one is that the screening in our country has been non-existent. We have a screening program now, which all of you should read about. It's published last year, and there are guidelines. A few guidelines are clinical, a few are on sonography, and if you don't have sonography, there is a criteria for X-ray and what to see on X-ray. And with every vaccination in the well baby clinic, the kids with high risk should be screened with these criteria. If you detect it early, then you can treat it conservatively with Paulich harness or close reduction and spica. Unfortunately, in our country, most often you will get a painless waddling or a limping child at 1.5 years. And it will take a long time for that to change. So at that particular age, the surgery has to be planned. The primary aim should be a good concentric stable reduction, right? Because he has come for dislocation, your job is to make it stable, and stability depends on not only good dissection and clearance of acetabulum, it also depends on the bony contours. So you should know how much internal rotation abduction is needed to give the particular varus derotation. And there is a paper which you had briefly put up, the British paper by Zagde, what tells you when to do which osteotomy. And residual dysplasia should be covered in older child by doing a Pemberton osteotomy for anterolateral coverage, incomplete triradiate, which is the most common osteotomy. And in older children, you will need shortening. That is very important. Whether to put a transfixing K-wire is an individual choice. Some people don't use it, some people do use it. But also, it is very important to monitor for avascular necrosis. Your case, look at it critically. The head is showing avian changes. The medial half of the head is not seen at all. Right? Go back to your X-ray and see you have an avian in that hip. So that will also need to be monitored, because the head may grow abnormally. And a long follow-up is needed till about adolescence, because we are seeing residual dysplasia, residual incongruency causing femoroacetabular impingement or instability at older age and subsequent arthritis. So there will always be another chance for you at adolescence to correct whatever is remaining by surgery, so that we preserve the hips. That is where we are today, to prevent very early age total hip replacements. Right? So that is where we stand, and you have to be very, very precise and particular in your exams if you are a postgrad.
Okay, sir. Thank you, sir. I'll keep
Thank
that
you.
in mind.
Thank you. Thank you, Dr. Sandeep, for your time today for the
Thank you.
teaching. And friends, today I personally gained a lot from all the three cases. at least it was a good learning points for me, and I am sure that all of you must have gained some knowledge about the cases, all three cases. Thank you all the presenters. Thank you for all the moderators. And again, in 2 weeks' time, we'll be back with another 3 sets of cases with their moderators. And we thank Dr. Ashish Phadnis today also for moderating this session, and Gautam from OrthoTV, as well as Dr. Ashok, Shyam, and Dr. Neeraj Bijlani from OrthoTV for supporting this event. Now I hand over to Dr. Ashish Phadnis for his concluding remarks.
Thank you very much, sir. And thank you very much to all the participants, Dr. Imran, Dr. Varun, and Dr. Ankita. It was really great to have you and hear out your cases. And I would also like to thank our sort of moderators and senior faculty, Dr. Iqbal Singh, Ghai, Dr. Sandeep, sir. It's good to see you again after a very long time. And
Ashish.
Rathod, who's sort of, I think, not there right now. And finally, my friends, Dr. Neeraj Bijlani and Dr. Shyam, for letting us use OrthoTV as their platform and making sure that this program reaches everyone and encouraging us to do more and more of these programs. I thank you all, and we'll be back in the next fortnight with another set of specialty-based case presentations. Thank you very much.
Thanks.
Thank you, sir.
Thanks,
Bye.
Ashish. Thanks, Mohanty, and all the